Apologies for the chairperson who couldn't be with us. Our first talk will be by Professor NOURELDIN ABDELREHIM. He's a professor and senior consultant of diagnostic and interventional radiology at Frankfurt University in Germany. Professor ABDELREHIM has got over 100 international publications. He's the winner of the State Prize of Medicine in 2015 in Egypt, and he's a section editor of the Interventional Journal of Radiology and Imaging Technology. Professor ABDELREHIM couldn't be with us today for personal reasons, so we've got his presentation recorded, and his presentation is about the role of interventional radiology in the management of GIT bleeding, a case series. Can we run the video?
Good afternoon, ladies and gentlemen. It's my great pleasure to present our clinical experience regarding the management of GIT bleeding interventionally in the International Congress of Radiology, ICR, organized by the Egyptian Society of Radiology 2023. GIT hemorrhage is one of the most important emergency cases that we have in our routine work, and as radiologists we have two important rules. The first rule is diagnostic by means of CT angiography, and the second rule is intervention by means of DSA angiography and embolization. For the management of GIT bleeding, we have two important rules, but which comes first, the CT tomography or the intra-arterial angiography? To answer this question, I'm going to describe with you a case of 84 years old female patient. The patient had a bleeding from a duodenal peptic ulcer, most commonly from the gastroduodenal artery. The endoscopy failed to control the bleeding. The colleagues asked me directly to do an emergency angiography with embolization, and they said that there is no need for CT first and go for angiography to occlude the bleeding immediately due as the patient is in shock. I did the diagnostic angiography, and you can see that by doing flush aortography, the massive arteriosclerotic changes of the aorta and iliac vessels, and there is aneurysmatic changes, but the origin of the celiac trunk and the superior mesenteric artery would not be easily to be identified. So I did a side view aortography, and you can see that the celiac trunk is completely occluded, and there is high-grade stenosis at the origin of the superior mesenteric artery, and there is a faint dissection in the proximal part of the superior mesenteric artery. So by all means, using different types of catheters, we couldn't be able to catheterize such terrible vessels. So it's important to go for CT. And you can see in CT the massive intraluminal hemorrhage with blood coagulation inside the stomach. And by axial scan, you can see that the celiac trunk is completely occluded, and there is high-grade stenosis and dissection of the proximal part of the superior mesenteric artery. And the sagittal view can confirm this one. So if you have a CT before going for angiography, you would manage the case by saying that it's by intervention. It's extremely difficult and cannot be done, and you have to go further either for surgical interference. This is important to save time of the patient. Don't forget, you are dealing with a patient who is bleeding now. So the sensitivity of CT is much higher than sensitivity of angiography, and it's considered the gold standard for detection of bleeding in the gastrointestinal tract. CT can detect bleeding between 0.3 and 0.5 milliliter per minute, while angiography can detect only bleeding between 0.5 to 1 milliliter per minute bleeding rates. And in other words, if CT does not show bleeding, so there is no need for selective angiography, and it's not indicated. We go for CT in three phases: native, arterial phase, and venous phase, in order to detect the bleeding being active and arterial, and these are the indications for the intervention radiologically. The CT give you a roadmap for the angiography and provide an information regarding the vessels and which side to select for puncture, for example, right femoral, left femoral, transbrachial, according to the state of the blood vessels. The GIT bleeding could be classified according to the source of bleeding into upper GIT bleeding and lower GIT bleeding. By far, the upper GIT bleeding is much higher in incidence than the lower GIT bleeding, 4 times at least. And the causes, either due to ulcers or varices or cryptogenic in case of upper GIT bleeding, while in lower GIT bleeding, mostly due to diverticles or angiodysplasias, colitis, tumors, and polyps. The course of bleeding could be controlled interventionally up to 95% in upper GIT bleeding, and the recurrence rate is between 10 to 30%, according to the anatomical collaterals of the blood vessels and the clinical experience and the embolized materials used. Surgical interference could be applied between 10 to 30% of cases. While in lower GIT bleeding, the success rate is higher, but don't forget there is incidence of ischemic complication in 10% being in vessels that they are supplying the lower GIT. The upper GIT vessels are mostly from the celiac trunk and the proximal part of the superior mesenteric artery, particularly the gastroduodenal and pancreaticoduodenal vessels, as well as the gastric vessels. While in lower GIT bleeding are mostly due to the anastomosis between the superior mesenteric artery and the inferior mesenteric artery with the Rayland anastomosis. So how to manage a bleeding from the GIT? In case of endoluminal bleeding, the first choice of treatment and management is the endoscopy, because they have different techniques in ligation of the vessels, and you can see the source of bleeding, for example, from an ulcer, either using bipolar or monopolar, diathermy and coagulation, spray, hemostasis, or clipping and bandage of the vessels. But when endoscopy fails to control the bleeding, so it will be the indication for interventional radiology by means of embolization. But their indications here should be an arterial bleeding, an active bleeding detected by CT, and the source of bleeding is detectable by the CT angiography. You cannot go for embolization if you do not know the source of bleeder. Different materials could be applied, for example, different sorts of sheaths, for example, the 5F and eventually long sheath to deal with atherosclerotic vessels, different catheters like Copra, Sidewinder, SOS Omni, microcatheters, and different embolizing materials could be applied to treat the bleeders, either microcoils, histoacryl, gel foam, and particles. This is an interesting case. You can see that the presence of endoluminal bleeding in the stomach. The endoscopy failed to control the bleeding. They applied clip at the source of the origin. However, there is massive bleeding from the gastroduodenal artery. They asked for an angiography. Here, the first step, the flash aortography. You can see the origin of the vessels, the trunk, the celiac trunk, the superior mesenteric artery, and by selective angiography of the celiac trunk, you can see the bleeder from the gastroduodenal artery, and there is a fine clip at the source of origin of bleeder which failed to be controlled endoscopically. Using a microcatheter to demonstrate the source of bleeding, this shows the contrast metal extravasation, and afterwards we apply the coils starting from below the source of bleeding and going up to include segmental occlusion of the vessels to prevent backflow from other collaterals. And you can see in the control angiography from the celiac trunk there is absence of extravasation as well as controlling from the superior mesenteric backflow from other collaterals. This is another case that I'm going to describe due to tumor infiltration of the duodenum from different metastases from an undifferentiated HCC. And you can see this is the tumor plush surrounding the duodenal and the upper GI, and you have to go for all these branches and collaterals and feeders selectively, and going to embolize either by microparticles as well as with different coils in order to get hemostasis from all these bleeders. This challenging case due to the feeders are extensive and multiple, so you have to go for all demonstrations of these vessels and to go selective occlusion of such collaterals in order to control the bleeders. And was controlled effectively. Case number 3, an aneurysm with the gastroduodenal artery, mostly due to either acute attack of pancreatitis or iatrogenic post-surgery, as in this case. And this is an aneurysm from the gastroduodenal. In diagnostic angiography, you can see that this is the aneurysm which is supplied by a branch from the gastroduodenal artery. So we used a microcatheter to go as distal as possible to the feeder, and then we occluded the vessels by microcoils. So this is before embolization and this is after embolization, and the aneurysm was completely and successfully occluded. Bleeding from HCC tumor rupture. This is also an important clinical case that we have. This is an HCC in the left lobe of the liver which is ruptured, leading to active bleeding subphrenically and perihepatically. And you can see in angiography that the extravasation that comes particularly from the left hepatic artery, and we did embolization. I used for this case libidol and particles to occlude the feeders, and it would be also therapeutic for the HCC. You can see here, this is the tumor plush and the extravasation of contrast from the left hepatic artery, and this is after embolization, complete hemostasis. This is a special case of ruptured HCC tumor. The patient had a TIPS, and in TIPS we shunt the flow from the portal vein through the systemic circulation. So the liver is particularly depending on the hepatic artery. It's important to selective embolization of the feeders of the bleeder and to avoid non-targeted embolization. So I did demonstration of the left hepatic artery, and you can see the bleeder coming from the left hepatic artery. I did through the microcatheter to the feeders of the bleeder or the bleeding origin, and afterwards followed by embolization using micro coils and avoiding non-targeted embolization in order to save the liver and to save the rest of. Another case of bleeding from a splenic artery, iatrogenic post-operative, and we catheterized the splenic artery and the celiac trunk, and you can see the active bleeding due to injury and extravasation of contrast, and important to go selectively and do the embolization of the bleeder. This is important measure. In lower GIT bleeding, for example, in this case where an angiodysplasia led to an active bleeding at the site of the cecum, we did a selective demonstration of the superior mesenteric and inferior mesenteric arteries, and you can see the feeders through the ileocolic branches, and this is the bleeding source. Of course, it's very important to go selectively with microcatheter till the source of bleeder, and afterwards to do coil embolization of the bleeder to This is another case of bleeding due to angiodysplasia of the right colon with involvement of the colonic flexure. The endoscope failed to control the bleeding, so we did angiography. You can see that the endoluminal extravasation of the contrast medium. Afterwards, we get selective catheterization with microcatheter, followed by embolizing the source of bleeding using a microcoil. It's very important to say it again that the lower GIT bleeding requires a selective embolization dealing with end arteries. So if you go non-selective, the risk of ischemia would be high. I would shortly describe the other reason of GIT bleeding due to the varices and portal hypertension. Liver cirrhosis is one of the most important reasons for portal hypertension due to occlusion of the blood-venous sinusoids of the liver, leading to increasing the pressure in the portal vein with development of massive esophageal varices at the source of bleeding. The principle of TIPS is to reduce the pressure inside the portal vein by means of induction of a shunt between the hepatic veins and the portal vein. We go through the internal jugular and then selectively catheterize the right hepatic or the middle hepatic veins, and then do a puncture the portal vein, and afterwards dilatation of the tract using a balloon, followed by insertion of a stent graft to make a permanent blood shunt between the portal vein and the hepatic veins to shift the blood pressure from the portal into a lower systemic venous pressure. And this will reduce the pressure and the risk of bleeding from the varices and will treat the main cause of variceal bleeding. Yes? This is a case of liver cirrhosis, portal hypertension, with the development of massive varices, paraesophageal and retroperitoneal, as well as at the hilum of the spleen. So, bleeding and failed control through medical treatment as well as by recurrent ligation, TIPS was indicated to reduce the portal hypertension. And you can see that by direct demonstration of the portal vein, you can see the giant varices, and the pressure inside the portal vein was around 32 millimeter mercury. So they decided to go for TIPS, and here the balloon dilating the puncture tract, and afterwards we inserted the TIPS stent and graft in order to maintain a permanent shunt. And this is the image post insertion of the TIPS, and the pressure was reduced to 10 millimeter mercury. Of course, after, it's also recommended to go selectively inside the varices and demonstrate these varices, and to occlude it by means of multiple coils, or even you can go for histoacryl and particles in order to occlude. So to conclude, CT is considered the gold standard for bleeding in the gastrointestinal tract. In addition to the precise localization of the bleeding origin, CT can provide information on the cause of bleeding and to help to make the therapeutic decision, either to go endoscopically or through intervention or surgically. Modern radiological procedures are based by super selective angiographic embolization of the primary hemostasis rate up to 90%, and the possibility for embolization of varices should be reviewed in the setting of TIPS implantation to include the variceal bleeding and the addition of embolizing varices and collateral vessels by means of coils or vascular occlusion systems showed promising results regarding the reduction of recurrent bleeding rates in different studies. Finally, accept my best regards and thank you for your attention.
Thank you, Professor NOURELDIN, and we